Hello and welcome to the third section of this recorded webcast. During the live webcast, participants discuss various issues using a parallel chat room. I'm briefly going to tell you now some of the points that were raised. First of all, people considered how are members of the public actively encouraged to participate in board meetings. Some of the issues raised by our participants in the webcast were that the typical way that the public was involved was as representatives of particular user groups. This is perhaps different to the approach taken by Great Ormond Street Hospital that you may have seen in the second clip. Typically, the public are invited to respond rather than to initiate proposals or discussions. Again, in contrast to what we saw here at Great Ormond Street. And their participation is very much affected by the effectiveness of the chair, bringing them in, giving them time to speak at the right time, the size of the meeting, whether the meeting is a huge meeting and people are overawed by the size of the meeting or the size of the room. These very simple domestic issues will obviously affect the active participation of the public, and this will depend upon really the chair's action. What factors influence discussion of practice issues at board meetings? Again, these are the suggestions put forward by our participants in the webcast. First of all, many of the participants commented on the excellent Great Ormond Street approach to a whole hospital and patient and family approach to communication and involvement. And if you haven't seen that clip, I do suggest you go back and look at the second part of this archive. The other two trusts as well, Medway and North West London, also showed examples of good practice by having regular items on the agenda such that a clinical focus is regularly brought in without it having to sort of come up in an ad hoc manner. Clearly other things will affect the clinical focus, so that if a central policy initiatives happen to be clinically focused, such as an NSF, a new NSF, that will affect the clinical focus. Or if there's a local problem with large clinical dimensions, such as overprescribing, this again is going to affect the clinical focus. But some of it goes back to these basics again of, is there an effective chairperson? Are clinicians vocal? Do they turn up? Are they there? Can they have time to be there? And can they try and link some of the other concerns of the board, such as financial concerns, into clinical practice, as well as current targets, both national and local? Clearly, I think from the examples that we've heard in the second part of the archive, a willingness to take a whole systems approach to the issues is very important in maintaining that clinical focus. And this is where board members need to have a good understanding of how the whole organisation works, and appreciation of different aspects, and not just look at issues with a sort of a rather single focus. Within our participants within the webcast, we had some colleagues from the USA, and they were able to tell us that they thought that in the USA there was probably a greater presence of patient and family influence in hospitals, and that hospitals try to delight patients, not just please them, but to delight them. However, they did mention that despite this greater focus on patient and family concerns, there was perhaps limited evidence that it actually improved clinical outcomes. Another question that the participants in the webcast considered was, how does communication between the board and the clinical staff work in their trusts? And this was perhaps summarised by one of the participants who said, well, it depends really on the occupational group. So GPs tended to communicate generally through maybe semi-formal networks and the quiet word in the corridor. Managers perhaps communicated more through correspondence, including email and documentation, and nurses may have some sort of intermediate pattern between those two. But clearly thought is needed on the relationship between the board meetings and other communication through the board, both before and after board meetings. So there's one more question we're going to look at, and that is the general comments on Medway, North West London hospitals and the Great Ormond Street hospital experience. The participants in the webcast commented that these three trusts had found ways to increase the clinical focus in what were probably very organisationally complex environments, large inner city teaching hospitals, really complex environments. So there was certainly some discussion and wonderment as to how they can do this and other trusts can't. So there's certainly a feeling that all trusts should learn from examples of good practice such as these. So that's the end of the comments. Our colleagues Ruth Endicott and Rod Sheaf are in the process of starting further research in this area, so if you're interested in discussing this further, please do contact them. And these are their emails showing now: ruth.endicott@plymouth.ac.uk and rod.sheaf@plymouth.ac.uk. So thanks very much for watching, and goodbye.